from Gangaram Hospital. Today I'm presenting post-operative management, which is very important in a vascular surgery patients. Vascular surgery patients remain at high risk for the development of complications in the post-operative period because of the complexity of their surgical procedure and their pre-operative comorbidities. Post-operative triage involves identifying patients at high risk for post-operative complication and triaging them to the appropriate care environments. The safest environment for the patient is determined by their preoperative medical comorbidity condition, inherent risk of type of operation performed, and ability to maintain the patient's intraoperative and postoperative hemostasis. Now we have two places where we can keep the patient versus admission to the intensive ICU, intensive care unit, and the high dependency step down unit. That is called HDUs. Advanced age, intraoperative blood loss more than 500 cc, and operative time, more than 5 hours. COPD, EF less than 40, New York class 3 and 4 angina, dialysis dependent, or have a need for continuous renal replacement therapy. Hemodynamically unstable patient in which systolic blood pressure is less than 90 or inotropic support at the end of the operation. Intubated patient with ongoing need for ventilatory support, ongoing transfusion, need for spinal drainage management, and perioperative cardiac ischemia. These are the all the patients in which we keep them in the ICU. Patient with pulmonary artery catheters, patients with spinal drains, patient with hypothermia, and those with required massive transfusion of blood products more than 3 liters during the procedure should be admitted to the ICU. Patient undergoing less invasive vascular procedure associated with fewer fluid shifts and lower surgical morbidities can safely be managed in a step units. That's called HUs. Then we hemodynamics and pressure monitoring. Indicators for organ perfusion to guide resuscitation includes blood pressure, heart rate, CVP, that is central venous pressure, pulmonary capillary wedge pressure, cardiac output, urine output, blood lactate concentration, tissue carbon dioxide levels, base deficit, mixed venous oxygen levels, and mixed venous carbon dioxide levels. Then we come to the center venous catheters and center venous pressure measuring. Center venous catheters are used primarily to infuse fluids, administration vasoactive drugs, and assess intravascular volume. Most common site for placement of center venous catheters are the internal jugular veins, subclavian veins, and femoral veins. Catheter must be positioned with the tip in the distal segment of the superior vena cava. More distal placement in the right atrium is associated with the potential risk for erosion, perforation, and cardiac tamponade. The transfusion must be zero at the level of mid-axillary line, and normal value of CFP are between the 6 to 12 mmHg. Then the peripheral artery lines. The peripheral arterial catheters are the gold standard for direct assessment of blood pressure and allow direct vascular access for the blood sampling. Complications include bleeding, hematoma, line infection, pseudoaneurysm, thrombosis, rarely limb ischemia. Most common site for cannulation is the radial artery, followed by femoral artery, axillary artery, brachial artery, and less commonly we use dorsal pedis and ulnar artery. Level of the transfusion midpoint of the right atrium, approximately 5 cm below the sternal angle in the mid-axillary line. Now we come to the pulmonary artery catheter, provides central hemodynamics measurements, waveform tracing, and specific blood gas calculations such as mixed venous oxygen and carbon dioxide saturation. Patient in cardiogenic or refractory shock and those in whom right ventricle dysfunction such as infarction is suspected. Echocardiography is used to assess cardiac function by measuring ventricular contractility, chamber size, valve function, and flow. Transthoracic echocardiography can be helpful in guiding hemodynamic management because one can easily differentiate between the left and right ventricular dysfunction and adjust treatment appropriately. Then we have a transesophageal Doppler USG is a non-invasive modality for measuring cardiac output. Then we have an intra-abdominal pressure measurement. IAP of 5 to 7 is considered as normal. Intra-abdominal pressure hypertension is defined as intra-abdominal pressure in excess of 12 to 20 mmHg. Elevated pressure may reduce blood pressure to the abdominal viscera. Abdominal compartment syndrome is diagnosed by the combination of the intra-abdominal hypertension and the evidence of the organ malperfusion. Patient, those who receive large volume of fluid for resuscitation, like more than 10 liters of crystalloids and 5 liters of colloid, or transfusion of more than 10 PRBCs during a 24-hour period at risk of developing compartment. Most commonly measured by the intravascular technique. Other techniques use nasogastric and orogastric tube. Then we have starting with the postoperative complication. First, we deal with the cardiovascular complication, in which first is hypertension. The causes are hypoxia, hypercapnia, hypervolemia, hypothermia, gastric or bladder distension, agitation, and pain. Neglecting to restart preoperative antihypertensive medication, that is the most common. Hypertension increases myocardial oxygen consumption and can potentially cause myocardial ischemia, increased bleeding from raw surface or through the vascular anesmosis. Treatment target should center on systolic blood pressure values 20 mg above or below the preoperative pressure and mean arterial pressure is more than 20%. Nitrates, beta blockers, angiotensin converting enzymes inhibitors, calcium channel blockers, and vasodilators are the most common classes of drugs we use. Hypertensive crisis causes acute damage to the end organ like heart, brain, retina, kidney. It is associated with a systolic pressure higher than 179 mmHg or diastolic pressure higher than the 109 mmHg. In absence of evidence of end organ damage, these elevation in blood pressure constitute the hypertensive emergencies. When such emergency is diagnosed, short-acting intravenous antihypertensive agent should be used. The reduction in blood pressure should be occur within 1 hour in hypertensive crisis and within 24 hours in a hypertensive emergency. The goal is to reduce the patient diastolic pressure to less than 110 mmHg within 30 to 60 minutes. Several agents can be used in hypertensive emergency. One of the most common and effective is labetalol, because it is combined alpha 1 adrenergic and non-selective beta adrenergic receptor blocker. And then we come to the hypertension. Hypertension is a dangerous and associated with increased risk of end organ dysfunction like MI, cerebral vascular accident, and renal failure, and possibly bypass graft thrombosis. Common cause of hypertension after surgery are hypovolemia, cardiac dysfunction, a diffuse vasodilatory state with or without sepsis. The management strategy for the correction of hypertension involves the administration of fluids and vasoactive agents. A fluid challenge should be first line of treatment of the postoperative hypertension. Surgical cause should be excluded. If the hypertension does not respond to fluid resuscitation, cardiac output must be optimized by pharmacological means. Short-acting peripheral vasoconstriction such as phenylephrine or dopamine can be used. In a cardiogenic shock and MI, inotrope agent may be necessary to increase the cardiac output. Finally, intra-aortic balloon pump counter pulsation may be necessary to aid the heart in generating cardiac output when pharmacological agents fail. Then we come to the arrhythmias. Patients with pre-existing structural heart disease are at high risk for the postoperative arrhythmias. Common triggers for the postoperative arrhythmias are hypoxia, hypercapnia, acid-base imbalance, electrolyte abnormalities, and myocardial ischemia. Treatment must focus on predisposing factors, and goal should be hemodynamic stabilization, control of ventricular response, and restoration of the rhythm. First type of arrhythmias are tachyarrhythmias, in which most common is sinus tachycardia, then atrial fibrillation, ectopic atrial tachycardias, junction tachycardias, multifocal atrial, AV nodal reentry, ventricular tachycardia, ventricular fibrillation. Tachyarrhythmias that transverse the AV node can often be controlled pharmacological by altering conduction through the AV node. Tachyarrhythmias that are conducted by accessory pathway and ventricular arrhythmias are more difficult to control pharmacologically than those that transverse through the AV node. Supraventricular tachycardias are common after surgery with the incidence of approximately 4 to 13% and after abdominal aortic aneurysm repair with an incidence of 3.2%. Prompt evaluation and treatment of predisposing factors such as hypokalemia, hypomagnesemia, hypoxia, myocardial ischemia are important to prevent sudden death. For sustained arterial tachyarrhythmia in a hemodynamically stable patient, the rate may be slowed with the beta blockers or calcium channel blockers. If unstable, they should be cardioverted regardless of the type of the arrhythmias. Intravenous amiodarone and adenosine 6 to 12 mg can be used instead of beta blocker or calcium channel blockers. Ventricular tachyarrhythmias are managed according to their duration and hemodynamically consequences. Hemodynamically stable monomorphic VT should be treated with antiarrhythmic followed by prompt cardiac evaluation. Polymorphic VT and ventricular fibrillation occur most commonly in the setting of acute MI and can rapidly lead to the hemodynamic instability. These arrhythmias are also treated with urgent defibrillation and intravenous antiarrhythmic drugs. Polymorphic VT with prolonged QT interval, also called torsade de pointes, intravenous magnesium should be given empirically for suspected torsade de pointes. Then we come to the atrial fibrillation. Atrial fibrillation is the most common arrhythmia encountered in the postoperative period. It affects 10% of the patient undergoing major non-cardiac operations. Common risk factor for development of AF include advanced age, male gender, valvular heart disease, and the previous history of AF. AF can be precipitated by hypokalemia, hypomagnesemia, volume overload, withdrawal of beta blockers, or angiotensin converting enzyme inhibitors. COPD, obesity, and obstructive sleep apnea and infections, especially pulmonary infections. Hemodynamically stable patients should have their heart rates pharmacology controlled with beta blockers, midodrone, distalis, or calcium channel blockers. Hemodynamically unstable have pulmonary edema, have ongoing chest pain, should undergo urgent electrical cardioversion. If the patient has been in an AF for longer than 48 hours or for an unknown period, intracardiac thrombus must be excluded. If intracardiac thrombus cannot be excluded and patient is hemodynamically stable, the safest course is anticoagulation with unfractionated heparin before cardioversion. Then we have a bradyarrhythmias. Bradyarrhythmias are not generally a diagnostic challenge and treatment options are straightforward. Those associated with sinus node dysfunction are sinus bradycardia, sinus pause, sinoatrial block, and sinus arrest. Postoperatively, these rhythms are most often due to increased vagal tone and myocardial ischemia. Treatment of sustained bradyarrhythmias and hemodynamic compromise is with anti-muscarinic agents such as atropine. If there is no response with the continued bolus dose of atropine, the patient must be paced either externally or with a temporary transvenous pacemaker. Postoperative myocardial infarction, MI is the most common cause of the cardiac complication and mortality in the patient with peripheral vascular disease. The three modes of detecting clinically meaningful postoperative cardiac ischemia are the symptom, the cardiac ECG, and the evaluation of the myocardial enzymes. ST, segment elevation myocardial infarction. Most common cause is acute rupture of atherosclerotic plaque and thrombosis involve coronary arteries. ECG must show ST segment elevation of at least 0.1 millivolt in 2 consecutive leads. In patient with pre-existing left bundle branch block and diagnostic of STEMI is difficult. Biochemically, the CKMB levels are elevated 3 to 12 hours after infarction. Peak at 24 hours can be elevated for 3 days. Cardiac troponin levels can be elevated 4 to 6 hours after infarction, peak at 12 to 48 hours, and can remain elevated for 1 week. Treatment involves rapid resuscitation with administration of supplemental oxygen, afterload reducing agents, antiplatelet therapy, anticoagulation with unfractionated heavy if at low risk for bleeding, and urgent reperfusion therapy with either fibrinolysis or primary percutaneous coronary intervention. Post-operatively, the fibrinolysis may be relatively contraindicated because this decision must be individualized to the patient according to the extent of surgery and time after the operation. Emergency coronary artery bypass surgery is reserved for patients who have failed to respond to the PCI or fibrinolysis or who have a complication that requires surgery, such as ventricular septal rupture, cardiac rupture, or severe mitral valve insufficiency. Beta blockers and AC inhibitors should have been started unless patients are hypotensive or bradycardic, are in a congestive heart failure, have AV block, or have a reactive airway disease. Then we have a non-STEMI, that is non-ST segment elevation myocardial infarction. Myocardial ischemia in this setting is due to transient reduction in the coronary blood flow that cause an imbalance in myocardial oxygen supply and demand, often with shortness of breath and decompensated heart failure. This ECG can decompensate non-specific T wave induction or ST depression, and the key to diagnosis is presence of circulating biomarkers, that is CKMB, troponin, iron troponin, indicative of myocardial cellular necrosis. In this also, supplemental oxygen should be administration. Pharmacological agent to decrease the preload and cardiac afterload should be given. Treatment can be thought of as the ABC, salicylic acid, angiotensin converting enzymes, beta blockers, and cholesterol lowering agents. In this setting of ongoing chest pain, the most recent American College of Cardiology, American Heart Association guidelines recommend the use of sublingual nitroglycerin if the systolic blood pressure is higher than 90 mmHg and the heart rate, diastolic blood pressure is higher than 90 mmHg and the heart rate is not less than 50 per beat or more than 100 beats per minute. If further analgesia is needed after nitroglycerin is given, morphine sulfate and mepridine can be used. Then we have the pulmonary management, in which that we have first mechanical ventilation. Mechanical ventilators affect oxygenation by controlling airway pressure and fraction of inspired oxygen, and affect ventilation by controlling tidal volume and respiratory rate. Patients are ventilated primarily in two modes. One is controlled, one is supported. In a controlled ventilation, the ventilator initiates and delivers a set of amount of tidal volume. In a supportive mode, the breath is initiated by the patient and supported by the ventilator. Uh, Ventilators may deliver either a fixed tidal volume with a variable pressure or a variable tidal volume at the fixed pressure. In which there is a variable pressure, we call it fixed volume. If we call it volume control, in which the pressure is fixed, we call it pressure control. Patient with hemodynamic instability on a severe respiratory distress should be placed on a controlled mode of ventilation to limit the work of breathing. Pressure support mode is generally used in patients who are more stable. It is important to ventilate patient with use of lung protective strategy to reduce ventilator-induced lung injury, which can occur through two main mechanisms. The first is referred to as a volume trauma, which cause over distension of alveoli due to high tidal volume and high alveolar pressure and can lead to the barotrauma, which is pneumothorax and pneumomediastinum. The second main mechanism is caused by shear force on alveolar endothelium. This shear stress are created in the alveoli by the cyclic opening and closing, and resultant injury is called atelectic trauma. The PEEP applied through the ventilator cycle serves to stent alveoli open, which prevents atelectic trauma and facilitate gas exchange. The ideal level of PEEP is unknown, but an aseptic range, depending on the clinical situation, 5 to 15 centimeter water of pressure is used in a PEEP. Then weaning. There are two main considerations in a weaning process. The first is the weaning the support provided by the ventilator. The second is removing the endotracheal tube, liberation from the ventilator. The patient should be assessed daily for the readiness to be weaned, which can be done after interruption of the sedation. This matter has been called wake up and breathe. With the traditional approach to weaning, patients are switched from the control to a spontaneous mode of ventilation, such as pressure support ventilation. The amount of ventilator support and PEEP is then decreased according to oxygen saturation, respiratory rate, and tidal volume. Once a patient are weaned from the ventilator, have successfully spent a prolonged time with a minimal PEEP on minimal pressure support, they can be assessed for the potential for the extubation. If any indication for the intubation exists, it is contraindication for the extubation. Contraindication to extubation are sedation, inability to protect the airway, presence of copious secretions, and lack of a cough reflex. Then tracheostomy. Tracheostomy leaves the patient of the portion of the work of breathing required to overcome the resistance to the endotracheal tube and the upper airway. It actually reduces the dead space. The major disadvantage of tracheostomy are the procedure-related complication, stomal complication, formation of tracheonominate fistula, formation of a tracheoesophageal fistula. Early tracheostomy within a week, first week in a patient who are thought to require ventilation for more than 10 days, facilitate weaning, and is associated with a shorter length of stay in the hospital. Tracheostomy can be done either by an open surgical procedure or percutaneously. Percutaneously, tracheostomy is relatively contraindicated in patients who are hypoxic, high PEEP requirement, those who are obese with short necks, those who are coagulopathic, and those with recent anterior cervical spine fixation, less than 10 days. Then we have a bleeding. Most common post-operative coagulopathy, in which first we check this prolonged APTT and a normal INR. The possible problems can be heparin, hemophilia A, B, C. Treatment for the heparin is a protamine, and the hemophilia is factor 8, 9, and 11. In which patient we have a normal APTT and increased INR. The most is warfarin, vitamin K deficiency, and drugs. FFP or vitamin K or prothrombin complex concentration or vitamin K can be used. Normal APTT and normal INR. We have a platelet dysfunction or thrombocytopenia, in which both with platelet transfusion can be given. Prolonged APTT and increased INR, primary fibrinolysis, disseminated DIC. Treatment underlying cause, then cryoprecipitated fibrinogen is less than 100 mg per deciliter. Tranexamic acid, FFP factors less than 25% of key platelet more than 50,000. Then we have a fluids. Fluids, if patient is in a shock, then we have to look for the blood pressure is low, low CVP, low increased lactate levels, low urine output, increased heart rate, pulse pressure variance is more than 12%. If Yes, bolus fluids. Yes, if it is improving with the fluids, then we have to give the fluids. If no, then we have to continue the inotropes. Evidence of fluid overload. We have a pulmonary edema, positive fluid balance, peripheral edema. If yes, then we have to give the diuresis. If no, we have to give the still the maintenance fluid. Then the electrolyte management, routine testing of sodium, potassium, magnesium, calcium, and phosphate should be performed. Magnesium and potassium level must be maintained in the normal range to avoid cardiac arrhythmias. Maintenance of calcium and phosphate level is also important for cardiac function as well as for the several cellular function. Both hyponatremia and hypernatremia require assessment of the patient volume status and careful to treat avoid adverse neurological complications. Then the transfusion of blood products. PRBCs we give if a patient is stable and there's absence of CAD, HB is less than 7, we can transfer. Stable patient with CAD, HB should be 8 or 9. You have to keep platelet, major cardiac surgery, unexplained bleeding less than 100 is a platelet. Coagulopathy with active bleeding less than 15. No active bleeding with febrile with coagulopathy less than 20. No active bleeding, low risk for hemorrhage. No fever less more than 10. Then the FFP active bleeding and INR is more than 1.5. INR is more than 1.5. And we have cryopressor active bleeding and fibrinogen level less than 100. The threshold is also fibrinogen level less than 100. Then the adjuncts in hemostasis is we have a recombinant activated factors 7, that is 7A, has been used to control bleeding in a patient with hemophilia type A and B. Recombinant factor 7A also generates thrombin at the site of vessel injury and induces coagulation. Antifibrillary agents such as tranexamic acid and aminocapronic acids and serine proteases such as aprotinin has been successfully used to treat postoperative hemorrhage. DAVP, a synthetic vasopressin analog that stimulates endothelin release of factor 8 and von Willebrand factor, has been used to enhance the platelet aggregation. Complications of massive transfusion. The definition of massive transfusion is replacement of 50% of patient's blood volume in 3 hours or one blood volume in 24 hours. Development of coagulopathy from multiple causes, including hemodilution, hypothermia, acidosis, secondary to tissue hypoxia, and DIC. Hypocalcemia because of the citrate used as an anticoagulant, and platelet dysfunction as a result of aging and metabolic alteration caused by storage. When RBCs are stored, their extracellular potassium level increases over time. So patients receiving large volume of RBC are high risk of the hyperkalemia. One of the most common sequelae of massive transfusion is acute lung injury secondary to congestion caused by the overload, alveolar inflammation, and increased permeability. Passive transfer of leukocyte antibodies and donated blood resulting in an immune-mediated transfusion-associated lung injury can also occur. Then we have a renal failure. Patients with preoperative renal insufficiency are at high risk for the postoperative renal failure. After vascular surgery, the major cause of postoperative renal failure is perioperative hypertension and ischemic injury leading to the acute tubular necrosis. Physiological patients are found to have a liguria, anuria, and rising creatinine concentration despite volume resuscitation. Strategies to prevent renal failure: we have fluid resuscitation, low dose dopamine and phenol given intraoperatively and postoperatively have been associated with some beneficial effect in patients with pre-existing renal insufficiency. Diuretic may improve diuresis, but they have no demonstrated effect on prevention of renal failure. Loop diuretic, a drug of choice when forced diuresis is used. Then we have the gastrointestinal ischemia. Chronic ischemia occur in 2% of patients after elective AAA repair and carries an overall mortality of 40 to 60% if it is a transmural. Then incidence of ischemic colitis in patient undergoing repair of ruptured area is reported to be 15 to 65%. Laboratory investigation often demonstrate anion gap acidosis and leukocytosis. In advanced cases, a plain abdominal radiograph may demonstrate free air in the peritoneal cavity or in the portal venous system. Stable patient with colonoscopic results suggesting ischemia limited to the mucosa may be treated conservatively with hydration and broad spectrum intravenous antibiotic. Unstable patient with the evidence of bowel ischemia should undergo urgent surgical exploration to reduce mortality. In selected cases of colonic ischemia that has not progressed to gangrene, reimplantation of the inferior mesenteric artery can be considered. Nutrition. The nutrition state of the critical ill patient have a direct effect on outcome. This is due to the metabolic stress that critical illness creates. Nutrition support in ICU has had the goal of maintaining lean body mass to preserve immune function and the avoid metabolic complication. This include delivery of both micro, macro, and meticulous glycemic control. Early enteral nutrition has been shown to be safe in patients admitted to ICU after major abdominal surgery. Nutrition in ICU can be subdivided between dosing and route administration. Once goal calories are determined, patient should be given 50 to 60% of goal calorie in first week of the ICU admission, thereafter increasing to the goal rate. In obese patient in which BMI is more than 630 with critical illness, permissive underfeeding or hypocaloric feeding with enteral nutrition is recommended. Enteral route has the most benefit than the parental route for the patient. In a patient stabilized on a parental nutrition, periodic effort should be made to start enteral feeding. Parental nutrition should not be stopped until enteral feeding is provided at least 60% of the target requirement. Recommended nutrition doses based on the guidelines are up to 20 to 25 kilocalories per kg actual body weight per day. In the acute phase to the critical illness, that is first 70 to 96 hours, then increase to the 25 to 30 kilocalories per kg body weight in a recovery phase. And we have a pain management. Effectively, post-operative analysis is important, may be associated with a reduction in the incidence of the myocardial ischemia after surgery. And in non-intubated patients who are able, patient control anesthesia PC pumps are preferred to intermittent on-demand narcotic dosing because patient can in a significant amount of pain while waiting for the next narcotic dose. Epidural analgesia can also be effective in post-operative period, and it offers the potential benefit of reducing the dose of opiates, which improves gastric emptying and ileus and increase patient mobility. Then DVT prophylaxis. General measures in postoperative care such as elevation of the lower extremity, early ambulation, leg exercise may reduce the incidence of DVT. Graduate compression stocking, intermittent wetting compression, and venous foot pump have also been shown to decrease the incidence of DVT, but they have not proved to prevent fatal pulmonary embolism and use as a monotherapy. And LMWH, unfractionated heparin at a prophylactic dose, is effective and safe in prevention of postoperative DVT. Then bridging the postoperative oral anticoagulation. Patient taking oral anticoagulants in the preoperative period requires specific consideration. Patients are categorized as being at low, moderate, and high risk. Bridging with full dose anticoagulation is recommended only for the patient at high risk, such as include those with the mechanical mitral valves or old model mechanical aortic valves. However, in a patient at low risk for stroke and thromboembolias, such as those with atrial fibrillation and no other risk for stroke, such as rheumatic heart valve disease, bridging may be unnecessary and potentially harmful. In a high-risk patient, oral anticoagulation should be stopped 4 days before and heparin started 2 days before the surgery when the oral agent is assumed to be become subtherapeutic. In absence of postoperative bleeding, bridging dose of heparin can be restarted within 20 to 12 hours after the surgical procedure. After minor surgical procedure, anticoagulant can be restarted on the evenings of the after surgery. Then we have alcohol withdrawal syndrome. Autonomic hyperactivity, including tremulousness, sweating, nausea, vomiting, anxiety, agitation, appears within the first 24 to 48 hours after the withdrawal in a patient who abuse alcohol. Symptoms can peak between the third to fifth postoperative day. Serious complications that may develop are delirium, tremens, and grand mal, epileptic form seizures. Delirium tremens, which occurs in 5% of patients abusing alcohol, is associated with an increase in post-operative mortality characterized by fever, tachycardia, hypertension, tremors, diaphoresis, hallucination, disorientation, agitation, and urinary incontinence. Before sedation is initiated for presumed alcohol withdrawal, hypoxia must be ruled out because the hypoxia is the most common cause of confusion and agitation in the post-operative period. Patient can be identified preoperatively to be at the risk by the quantity and frequency of their alcohol consumption. First line of treatment for the patient with alcohol withdrawal is benzodiazepines. Treatment of severe alcohol withdrawal may require intubation and admission to the ICU. Beta blockers may also be used to reduce sympathetic overactive and cardiac complications. Seizures should be treated with intravenous benzodiazepines. All the patients should be given daily thiamine and multivitamin to prevent Wernicke's course of syndrome. Then we have a sedation and delirium in intensive care unit. Adequate pain control and anxiolysis with appropriate sedation and analgesia as goal. for monitoring of the sedation agitation score, the motor activity assessment scale, and the Richmond agitation scale, that is called RAS, in which we can see there's a 0 to +4 and 0 to -5 are the uh, scales scores, in which 0 patient is alert and calm. As we go towards the plus, the restlessness, agitation, very agitated and combative. So, and as we go negative, the patient become more drowsy, light sedation, moderate sedation, deep sedation, and unarousable. Uh, then we have consciousness is considered as a combination of level of arousal plus the content of this consciousness, such as delirium. The confusion assessment method for ICU, what's called CAM ICU, is a delirium monitoring tool. Critically ill patients, those with pre-existing cognitive impairment, advanced use of psychoactive drugs, mechanical ventilation, untreated pain, and sleep deprivation increase the risk of delirium. We have three types of delirium, which is first is hypoactive delirium, hyperactive delirium, and mixed delirium. Hypoactive is the more common, in which patient is slow down, lethargic, flat, affect is flat, withdrawn, lack of attention. Hyperactive delirium less common presentation as psychomotor agitation, restlessness, affect is disinhibition, aggressiveness. Mixed in, we find out both the features of the hyper and hypo. Uh, Independent predictor of higher 6-month mortality is the delirium. Then this is the CAM ICU flowchart, in which acute change of fluctuating course of mental status is present, no, then CAM ICU negative, no delirium. Inattention, squeeze, when we say squeeze my hand, this is a chart we follow. CAM ICU negative, and this is the orange one is the altered level of consciousness, current RAS level, RAS other than 0, CAM ICU positive, delirium present. Treatment of delirium can be divided between the use of non-pharmacological and pharmacological agents. Non-pharmacological measures concentrate on minimizing risk factor with repeated reorientation of patients, early mobilization activity, non-pharmacological sleep protocol, timely removal of catheter and lines, unnecessary noise and stimuli are minimized. Patients are given their normal aids such as glasses and hearing aids. Pharmacological strategies first involve the reduction and removal of unnecessary sedatives and analgesics. Many drugs, such as benzodiazepine, used to treat confusion, often exacerbate it. Lorazepam is a well-recognized offender. Pharmacologic agents with a pro-cognitive advantage, such as haloperidol, have also been recommended for the treatment of delirium. This is the uh, harm reduction model, in which the mobility makes it better, sedative is make it worse, and sleep makes it better.